Good morning, everybody, and welcome to our next session, which is going to be around lip optimization. And let me introduce myself. I'm Dr. Raja Kulla from the UK, cosmetic dermatologist. And what I'm going to be giving you an insight into is some of the aesthetic ideals around lip augmentation and enhancement, looking at objective strategies and protocols to inject the lip, in particular a 6-point injection technique. So, of course, this is why we inject the lip, because women and sometimes men are aspiring to having beautiful lip and perioral regions. Their stimulation for this is often the most beautiful women in the world, and you can see they come from a variety of different ethnic backgrounds, and they present in different shapes, sizes, and configurations. But one thing that they do tend to have in common is that they tend to fit the aesthetic ideal. The lip shapes change through aging, and we know that the aesthetic ideal tends to be the heart-shaped lip on the top left-hand side. So you can see here, a heart-shaped lip has a good balance, 1/3 to 2/3 to upper lip ratio, a good strong glog-outline point, Cupid's bow and philtral column, as well as a nicely everted lip, which is important for red or mucosal show. Now, as we age, you can see going around to elliptical, then apple, then to ribbon, then to bow. You can see that the lip is inverting, it's closing, the proportion is lost, of course the volumetry is lost, but more importantly, the mouth becomes unhappy, and our colleague Frank Rosengast will be telling us about the happy face shortly. So in terms of lip aesthetic ideals, this is a little bit more complex, but we kind of do this subconsciously, just using the computer that is our brain, and we know what to do with our needle. But let's go through this objectively. So, first of all, balance. 1 to 1.618, upper to lower lip ratio. That's 1/3 to 2/3 of volumetry distribution. Then, of course, you have a positive upturned corner of the mouth, a nice strong vermilion border with an eversion and open mucosal show, a strong glog-outline point and connection of the philtrum ridge as it goes up towards the nasal septum, and, of course, a heart-shaped lip. If we look at geometry, it also plays an important role in our practice. So look at these two lines here. You have the ricket line, which connects the nasal tip to the pagonian. The anterior limit of the lip, when viewed in a lateral view, then it should not be more anterior to this line. The Steiner's line, again, is from the nasophiltral angle to the pagonian, and the anterior projection from Steiner's line should be, ideally, 1 to 2 millimeters. So we've got good landmarks to work towards here. And what happens when the lip ages? Well, I was involved in the scientific evaluation of Juvederm Volbella in 2011. And what we did was we graded the lip using a validated scale 1 to 5, but it also corresponds to aging of the lip. You can see here that during lip aging, there's an inversion, a closure of the lip, thinning and narrowing. Then we see a inversion, negative depression of the oral commissure, so sad corners, and then also perioral lines. So we can treat all of these indications with our fillers, and we know that when the patient consults us, it's important to manage their expectations that we're going to take them up roughly 1 grade, maybe not 2 grades, so otherwise we're not going to be able to meet what they want. And if you look in the lower third of the face, look at the other anatomy that's happening here. Sad oral corners, elongation of the philtrum, flattening of the philtrum, perioral lines, shortening of the chin. So all of a sudden the ratio changes from, it should be in the granddaughter, 1/3 to 2/3, white upper lip to chin, and then it elongates and becomes almost 50-50 during aging. Now we also look at the muscle here. Orbicularis oris during aging, it becomes hypotonic, it elongates, and it loses its concavity. It becomes a little bit more convex. And sometimes you can have a double ring of contraction, which gives a horizontal line in the lip that sometimes we need to restore the philtral column with. Here's a histology slide of orbicularis oris. You can see the fibers are thinning when compared to the younger fibers during youth. And the modiolus is the fibromuscular mass here at the corner of the mouth. It is the insertion point for 7 lower facial muscles, and its position dictates the positivity or negativity of the lower facial posture. So, of course, if we affect muscle balance and we weaken lower facial depressors and allow elevators to become more dominant, we get a more happy face. So here we go. We inject in a Nefertiti type arrangement, which was described by Philip Levy, and this can give nice effects of oral corner lifting, especially in those patients with good skin quality. Here's a lovely dissection from Lakhdar Belarui, showing the modiolus. You see the starfish structure in the corner of the mouth, fibromuscular insertion point for those facial muscles, and its vertical position dictates the happiness or sadness of the face. Again, look at this dissection. The preferred injection depth for lip now is moving away from being deep. So instead of injecting into the retroorbicularis oris fat compartment, you're injecting into the intradermal, submucosal, or just supramuscular territories. And that's really to give eversion. So here it is, 6-point injection strategy. So we begin in the lateral part of the lip, then move medial. So number 1 is to give positivity of the oral commissure. Number 2 is the area where we see a triangular depression in the lateral part of the upper lip, particularly in those patients that are more aged and they have buccal herniation. Number 3 and 4 is for vermilion, eversion, and also for the perioral lines, and then we get to Glogau-Klein point, filtral column, and then we do the volumetry. And this is how it works in the patient, lateral to medial. Dry, actinic, dehydrated, inverted lips, and all of a sudden we restore the definition and detail, and the beauty is in the detail, not so much in the volume. We don't do so much plumping these days. Again, young patient, 29 years old, a little bit inverted, but she lost her definition in the Glogau-Klein point and the filtral column, which blunts the beauty of the lip. So when we restore this detail, all of a sudden the lip comes to life. Lots of risks though. Top picture is for ecchymosis of injury to the superior and inferior labial vessels. And then the lower picture is hypersensitivity, which is very unlucky, 1 in 30,000 patients. Let me show you a video of a technique for the 6-point now. So really we're going to go from lateral to medial, lift the corner of the mouth, evert the lip, then deal with the Glogau-Klein point filtral column, perioral lines, and then we'll do some volumetric change. So this is a lady I injected in Australia last year. She was very compliant, as you can see here. So tiniest intradermal injection, and all of a sudden, look how that corner of the mouth just pops up, like it's got a piece of string attached to it. And now the next job is to evert the lip. We want to give a little bit more mucosal show. So look how I'm in the white part of the vermilion here. I'm not injecting in the red tissue. It's barely subcutaneous injection. And I want to leave a little bit more medially and less laterally, like a comet tail type of effect. And I mold and massage the tissue here, conform it to the vermilion. And now I'm showing more red tissue on the left than I am on the right. So the next job is going to be to restore the Glogau-Klein point, just here, and also its connectivity through to the philtrum. And again, this is going to be a reverse cone effect, so less superiorly and increasing the amount of injection as I come inferiorly. Down here to the Glogau-Klein point, you can see it expanding, and now a small little mold. Now, there's a surface tension improvement here. Look at how the perioral lines have already started to reduce, because we're restoring the frame of the lip tissue instead of needing to inject lines and wrinkles, which we don't do so much these days. But if you want to go direct, there's still an option to do so. So you can take a perpendicular approach to perioral lines and wrinkles, and then you can inject them intradermally, so very superficially, especially using a low molecular weight hyaluronic acid product. And what you're doing is you're pushing the skin away from the wrinkle either side and improving surface tension and turgor, which completely obliterates the perioral lines. In fact, what happens because of surface tension is that you get a midline deviation and the Glogau-Klein point is pushed to the non-treated side. Now, we used to do a lot of pad work, and we used to inject the product here, but we used to inject from the inside of the lip. So Boris Sommer had described a technique which is a cutaneous approach coming from the external part of the lip, so from the white tissue, and you can access from an oblique angle, so superior laterally, and this is subcutaneous, and then I'm just going to wash HA in behind the mucosa where I've left a little bleb there. More medially, less laterally, and then a very slight little mold just to make it comply with the tissue. And we now have volumetric balance. If you wanted to augment the lower lip further, you can do the same approach on the lower lip. And the key really here is that the lip is not just a resting piece of anatomy, it's a dynamic anatomy. So it moves, it smiles, it eats, it laughs. So it needs to look good when you're resting, but also during full facial animation. And of course, perioral lines and rhytids is something that's of great concern to our patients. So we've obliterated the perioral lines of the upper lip. Now let's have a look at the volumetry of the lower lip. So again, I'm going to use a cutaneous approach, so the reciprocal point for GK point in the lower lip, and this is where I'm going to wash the HA in behind the mucosa. But to save the patient the pain and also to minimize bruising, a cutaneous approach here, in behind the little dot of product, at the wet-dry junction, I make a bump. This is what a lot of beautiful women have, is the tubercle either side. And then I'll just mold and conform that to the tissue. And you can see now that her volumetry is much more balanced and that she has a very nice result there. And I think she'll do one final kiss now just to show the resolution of the dynamic problem. You can see on the treated side eversion, and look at the depression and the collapse of the tissue on the untreated side. So thank you very much for your attention.